Very interesting case we'd like to show you. The patient case history, 67-year-old male who has a history of chronic kidney disease, stage 5 diabetic nephropathy with a creatinine in the high 400s. He has a history of type 2 diabetes as mentioned, hypertension, dyslipidemia, he's a smoker, and he has remote bacterial meningitis complicated by some hearing loss requiring a cochlear implant. His current presentation, he presents with respiratory failure, was intubated and ventilated along with acute coronary syndrome with the troponins in the 700 range. There were some challenges with extubation. His EF was noted to be 30%, and due to persistent heart failure, he was sent for coronary angiography. The angiogram was done as per routine, demonstrating a large left main with distal calcification, as you can note, ostial calcification as well in left entry descending, and ostial large circumflex disease with some mild disease in the mid-segment. The spider angulation, this better shows the ostial circumflex angulated calcified lesion in a large vessel as previously mentioned. And in the cranial angulation, you notice that the proximal LAD does have severely calcified disease with an occluded segment in the mid to distal, which we felt was chronic. The image of the RCA demonstrates a circumferential calcified lesion, at least on angiography, in the proximal segment, which appears significant in a dominant vessel. Recognizing his left ventricular dysfunction and his multivessel disease, he had testing done, including a CT abdomen demonstrating patent iliacs at 7 millimeters in the minimal size, and echo demonstrated no LV thrombus, so we thought he'd be appropriate for percutaneous ventricular assist. So the case plan for today was recognizing this guy as calcified left main and RCA and LV dysfunction. Cardiac surgery assessed him and felt that he was not a candidate for surgical revascularization and was brought back to us for consideration of complex PCI. The plan today was a left femoral CP, which was Impella CP, which was pre-closed in a 10-2 fashion, as per usual, along with the right radial 7 French access for the intervention.
So we've got a 7 French AL guide. We've done a OCT run that we've co-registered. So as Dr. Cass has shown, the RCA has 2 severe lesions and is severely calcified. And you can see that here on the OCT. As we go through, there's a large lumen, some nodular calcium here at the distal end of the prox of the mid lesion. And as we get into the segment that's diseased, you can see we have loss of lumen and we have diffuse, fairly concentric calcification here. And then we'll go through to the proximal lesion as well. And similarly, there we see diffuse calcification in the little bit of blood swirling. In the lesions, we don't see nodular calcium. So our plan here is to use IVL, and we've sized it, as you can see here, and measured our reference lumen size. So we're going to take a 4.0 IVL to both lesions and do lesion prep and plan to try to treat this with one long stent. I think if we had a large nodule that was impeding the lumen significantly, then we would be better off with atherectomy to try to modify that nodule. I think IVL is effective, but if there's a large nodule there, I think you're better off doing upfront atherectomy.
What do you think about rota versus orbital when you deal with nodular calcium?
Yeah, good question. I think our group has a lot of experience with rotational atherectomy and less so with orbital. So we've used mostly rotational atherectomy for that indication, but I think both can be effective.
You just cross it.
Yeah, I think we're just across. Let me just give a small puff to make sure we're in the right zone.
You're just past it.
Yeah, I could probably come back a bit. The emitters.
I'll give you a puff there just to see where we're landing it. So that actually went pretty easily. I'm impressed.
Yeah.
I usually have quite a bit of trouble with the IVL, almost as big as a stent to cross.
Perfect.
Yeah, you're right across the lesion there.
Great spot. Okay, I think we could go up to 4. I'll let you do the emitting.
Sure.
Going up.
So with our IVL balloon, we're going to go up to 4 here. You're up, and we're going to start delivering therapy. There we go. See if there's any change in the lumen there. I think it expanded not too bad.
Okay, down 6. So we gave the therapy at 4. We most dilated it to 6.
We get the guide back, just don't flow into that right.
Kick the guide back a bit here. There we go.
Perfect.
So we concentrate the treatments here until we see that we get symmetrical expansion of the balloon.
Can we zoom in on it, take a look at it?
Yeah, sure. Good.
Let's see if more.
And we'll go up again here.
Go for it.
Up. Yeah.
Perfect. We're going to deliver some therapy here. Right now we're up at 4 atmospheres. The city there. It's actually not bad at all.
It's expanding. It's a big vessel. We measured it 4 by 4.8.
Okay.
Down 6 again. You can see the balloon prep is excellent. We don't see any air in there, so we're allowing the energy to transmit.
Do you want to hit the prox too on the way out, or what do you think?
I think so for sure. I think we'll maybe try to deliver a few more therapies
Sure.
to make sure we get it well expanded. Up again.
That looks even better the second time.
Yeah.
Okay, delivering therapy right now. Good.
It's good. Six.
And a lot of things that help us even delivering such a large balloon in there. AL1 guide, 7 French. You know, we can't get away from having really good guide support. This is a really.
What do you think about some therapies distally? Just distal to the balloon.
I think we just got it right, and I think our balloon was even distal.
Small cine here. Let's see how it works. So I think we could.
You're right. There's a nodule there, but I think that we will be able to get away from.
So I think we can treat the prox, and then if we wanted to, we can do an OCT run.
Yes.
Just to ensure we've got proper modification, so we don't end up with a stent regret situation.
I think you're in a good spot.
Oh. Yeah. I think that's a good area.
Yeah, I think you're right. Hanging out the ostium there. Perfect.
So this is going to be the proximal lesion there. That's up.
Okay. Delivering therapy here. We're at up at 4 atmospheres. So it really helped us to size the vessel appropriately, knowing that getting appropriate IVL balloon size.
It's down 6 again. I think we can just take this out and do an OCT run.
I think that's a great idea. See what the modification is. Let's just fire there. I remember last time we pushed it in, this thing, the
Right.
RX part of the OCT eventually gets fatigued.
If you have a look at the balloon up there, the distal nodule is fighting you. That might be a challenge as well.
Let's see.
Yeah. Should be good there. That's perfect. And
Let's
then
try
we'll
that.
back it out after. Perfect. Let's take a little further.
A little bit more, just past the. There we go. You got it. That's a good
We
spot.
can back our guideliner out. Yeah. Maybe position it right about here. Okay. I think that should be a good image. Yeah. Okay. We're looking for lumen gain as well as calcium fracture. Which, as you mentioned, I think we saw on the quick glance at the OCT. Yeah. So we see here, you know, as we get into this area, we have lumen gain. There's the wire artifact, but we do see areas of calcium fracture.
That fracture on
here.
top for sure.
Yeah, right here
Yeah.
about 11 o'clock. Large calcium fracture down here at 5, as well as at 8 o'clock, we see calcium fracture. And that fits with what we see angiographically, as well as with the IVL balloon going up, that we've gained lumen. Here we've got fracture back here. So we've got several areas of calcium fracture and, you know, pretty large lumen now, almost 5.5. So I think at this point, what do you think? I think
I think we're trying an NC balloon.
Yeah, you want
Maybe
an
a
NC
4.5?
or you want to just stent it?
I'll go with an NC just to make sure.
Sure. You want to take a 4.5 NC balloon?
Let's go with a 4.5 NC.
Sure. We can
Let's
take
do an
that.
ACT. See if our guideliner in there. Yeah, let's go with a 4.5 15. Perfect. You can puff there. I think you're right across it.
Go ahead.
Let me know when you're ready.
Go ahead. Perfect.
That's it.
I think you can go up.
Okay, we're going to go up.
I'll take it to low pressure, go to 6, see if it expands symmetrically.
We're going to go up to 6. We're up at 6.
Now let it fill. Maybe a bit of air in there.
Let me just reprep it there.
Yeah, sure.
We're going to go up again. We're up at 6.
Very
Let it
nice.
fill up. Let's see. Oh, that looks nice.
It's good. And you can see the calcium on either side, you know, it's good.
Okay.
And we might as well treat the prox on the way
Yep.
out. You can see we're getting a bit of damping from the guide, so it's probably not perfectly modified yet.
Good.
Perfect.
That's the spot. Going to go up with a 4 or 5. We're up at 8 again. You get an idea where the ostium starts. I think that's perfect.
That looks like a good spot there, I think.
I think it's perfect because you have another 2-3 millimeters right to the os.
Come down, yeah.
Down from 8.
So now I guess we have, we measured it at about sort of 36 when we met our landmark. So
Let's
we
go
can
with
take a
38.
38 stent. We should
Yeah.
be able to cover it. For short, we'll put another short stent there. So we could take that 4038 Promus, please. So I think that's the advantage of being able to image up front. You, especially in these calcium modification cases, you know how much calcium you have, what type of calcium, what type of device you need to use. Do you need to use atherectomy? Can you go with specialty balloon or regular NC balloon? You get your length, you get your diameter, so you can really, we'd pick the stent up front, knowing based on the OCT imaging and the diameter and the length, and we've already picked our post dilatation balloon as well. So we're in good shape.
I think it makes a huge difference. Like this would have been definitely a situation that without imaging, you could definitely fall into stent regret. The upfront lumen wasn't very stenotic. You probably could have gotten away with maybe a 3.0
right.
NC. The expansion, given such a large vessel, would have been misleading.
And we see that, you'd easily be able to open the lumen up, like you said, with an NC that's undersized.
Yeah. Perfect.
Okay.
It's a perfect length. We almost be able to cover the whole thing.
Yeah, I think we'll be
based on my eye, it
close.
looks like that bend was.
So let's step a puff there. If we're short, we can make a decision here.
I think we might be able to get away with one. I'm going to give you a test here.
Yeah, we can come back a little bit there, I think, to get the os.
Yeah. I think it looks really good.
Comfortable going up there. Yeah, I think that's a good spot.
Let's do it. Going up with our 4038. I'm at 14. A little bit of a drift here and perfect.
Wow, nice result. Good expansion there.
So do you want to get our guideliner in? And
yeah, we'll come back, I think, with the
4.5.
4.5 NC again, based on our measurements. And then we can finish potentially with an OCT run.
Yep.
What are your thoughts on using IVL compared to other specialty balloons such as OPN, particularly for de novo? I know OPN we've used quite a bit for stent regret cases, but what do you think about de novo lesion for calcium modification?
I think in lesions, for instance, such as this, it does have a role. Lumen in itself is enabled to get the OPN in, but I still favor at least debulking it in a way, either with orbital or creating fracture to really be able to get lumen gain.
Right. Should go now. We got the guideliner fairly deep. There we go. There we go. Well, persistence.
Exactly.
Okay,
Perfect.
Great.
Let's see. I see such a large vessel. Time difficult to inject with the
manual. Yes.
With the manual.
Let's see how it looks.
That looks really good.
I think that's a good result.
That's a fantastic result.
That's a great result. Yeah. Knowing he's a patient with diabetes dialysis, he's going to have a very high risk of ISR and stent failure. So you want to try to optimize the results as much as possible with that much calcium. So we'll switch to the left.
And it looks like the CP is doing its job. I think we have very stable hemodynamics.
Yeah. Output of about 2.6.
Yeah.
Perfect.
We're on P5 now.
Great. Save the best for last.
I know. Very tight circumference. I think there's actually nodular calcium right at the distal left main at the ostum of the circ.
Yeah, often there is in that spot. Yeah, it's difficult to modify.
You can see there's a shelf of calcium within the LAD. Mm-hmm. But I think our major concern is making sure that circumflex is
it's a huge territory for him.
Again, I suggest just wire.
I think we balloon,
OCT.
Yeah.
Again, based on the size of the vessel, I would go with a bigger burr.
I think so. Yeah, I don't think that taking a 1.5 is going to make much modification.
Yeah,
that's good. We're good.
Yeah, we got it. We'll go with a 3.0. Get some room to get our
Give us some
OCT
time to work. We
in.
have the CP in, but I think we want to still, even with the hemodynamic support, we want to minimize the amount of ischemia we're causing.
Right. I'm not sure even OCT would even cross that.
Probably be obstructive. Yeah.
You think it's much more fibroelastic than we think?
I think knowing his underlying conditions and the angiogram, I think it's going to be a lot of calcium there. Go ahead.
Going up there. Let's see. I'm going to go slow.
Slip.
Perfect. We're at 12. That looks good.
think we'll try an OCT run here.
I agree.
Yeah, see what we can learn. So yeah, I think the imaging will be important here. If we find that we don't have as much calcium as we think, maybe we can modify it again.
I would still give some
atherectomy.
IVL. Do you think IVL?
I think
Should
so.
we go to 4 at least?
Yeah, I think at least, yeah, but we may not need to use atherectomy here. Each of these, we're not using a lot of contrast here either.
No.
We're manual, but we're not having to use too much. So interesting, even on the, when it's reconstructing on the long view there at about 25, you see a large protrusion coming into the lumen, which is likely a nodule in our area. So let's see if we can just quickly co-register this. I find it always helps to co-register the image. Yeah, okay, great. I think it's not, we'll have to move
there you go.
Okay, so, if we pick a landing zone.
That's actually a good landing zone.
Yeah, I mean, there's a little bit of eccentric calcium here, but huge lumen. So, I mean, realistically, even if we landed it here, we'd probably be fine. Let's see what's going on here. Right. Yeah. So some balloon injury. But yeah, I don't really see a large nodule there. We probably have a dissection plane from the balloon injury. So I think we'll take an IVL for oral IVL. Yeah.
What do you want the LED? It looks like there's a lucency right in the middle of it. Is that calcium or?
It almost looks like it's a recanalized.
Yeah, I think it's a double lumen do a cranial view.
Yeah.
That's a spot.
Right. I think that's a good spot. Yeah, we got the.
I'm going to go up there. I'm going to go up to 4 here. I'm going to go up with the IVL. We're up at 6 actually.
Let's come back. I think it's just known. See this instead of giving the therapy. Yeah, we see that often. Osteal circ. I think that's very common that we get a little bit of nodular calcium or calcium we can't expand.
I go slow here.
Good. I'll keep some back pressure on the balloon.
Gently. I'm going up to 2. Well, there we go. It's a little bit of. It's coming back again.
Let's bring it more in. Yeah.
Yeah, just leave it there. See if it pops back.
Go ahead.
I'm going to go up slow here. 2, 4. I think it's not bad. Let's do some therapy here. We're at 4. I need a waste there.
I think we'll give all the therapy.
You want to come all the way to the left main just to make sure?
Yeah, I think because
it's the left main. There's nothing. Yeah, if our 4 goes nicely in the left main. Pull it back and just straight into the left main.
Sure, I think you're good there.
That's it.
That's a good spot.
I'm going to go slow so it doesn't jump back forward or back. Excellent. Okay, we're at 6 here.
Oh yeah, that looks quite good.
That's very good. What do you think? Cutting balloon? Are we happy with another OCT or just stent?
I mean, we've got great expansion here. We've just sized it with OCT. I think we just stent it at this point.
I agree. Should we wire the LED or no?
We could take it down. Let's take a cranial view, as you said. I think that'll demonstrate, there's not much distribution to the LED here.
Yeah.
And as you said, the ostium looks like it's in good shape. I think that's good.
Yep. Yeah, let's go with angio, cranial view, caudal view, and we'll go with our stent. I'm already thinking about that mid-segment. Once you put a large stent in that proximal, it's going to be a different story.
Absolutely. Wow, that's
very nice.
Very nice to modify. You can see it's still a bit eccentric, but we've really modified it nicely. I think we could probably go, we don't need to come down